Hi, everyone, and welcome to our 74th virtual shadowing session. My name is Taylor, and tonight we have for you a session titled Inside Emergency Medicine and Critical Care with Dr. Avi Ruderman. Next slide, please. As always, we have our virtual shadowing working group, which also includes our four physicians, Dr. Fowler, Dr. Salazar, Dr. Morchetti, and Dr. Reno. Next slide. Just to let you guys know, next week we're going to have a specialty spotlight in urology with a doctorate of nurse practitioning, and then we're going to have a DO specialty spotlight in PM&R, followed by what was to be decided, which will now be a session with Dr. Reno as she discusses an emergency medicine simulation course that she's created. Next slide, please. And as always, if you have any questions, be sure to contact us via Instagram and our website, but also be sure to put your questions in the chat as we go tonight so we can try to answer those during the two Q&As, the one at the middle and the one at the end. Dr. Fowler, do you have anything to say?
Well, it's so good to welcome you all once again for our 74th program. We've had a wonderful success sending material for you as you plan your healthcare careers. We've had 500,000 viewings of our program, so it clearly means that having a web-based content is important for students all around the world. With the admissions committee season this year, we are definitely seeing many students who are applying, and they're using their virtual shadowing hours in their applications for medical school and beyond. So it's great to have you. And Taylor, would you please introduce our guest for this evening?
Yes, if you guys could please give a warm welcome to our special guest, Dr. Avi Ruderman.
Good evening, everyone. So my name is Avi. I am an assistant professor of emergency medicine at UT Southwestern Medical School, which is in Dallas, Texas. This is a picture of my fiance and I. She is an ophthalmologist who is now a day trader. And my ultimate goal in life is to become a house husband. So that's my backup plan right behind me. I am originally from Essex County, New Jersey. Decided to point out on a map for you guys, for those of you who've never been out east. It's on the East Coast. Feel free to visit sometime. When I first moved to the Midwest for fellowship training, I was told that I need to wave to cars when they let me in on the road. And I explained that we wave all the time on the East Coast, but we only use one finger. So that's me on the right-hand side of the screen. Kind of had an early start getting into medicine. Just to share a little bit about my background and culture, there's a big debate in Judaism about abortion, and the fetus generally isn't considered viable until it graduates from medical school. So I was actually pretty fortunate to make it this far. To level with you guys, I went into medicine primarily so that I was looking for a field that would allow me to support my family the way that my father was able to support mine as a neurologist. And I wanted to be in a field where I had a reason to get out of bed in the morning, and medicine does that for me, especially emergency medicine in particular. So I'm going to try and impart a few life lessons to you over the course of this evening. The point of the slide is to tell you that for the most part, the most immediate thing that you did is what's going to most directly impact the next step that you want to take. So if you imagine somebody walking out of the water onto the beach is eventually going to wipe away the earlier steps, and so you're left with the most recent ones. So I went to a public high school. My GPA is irrelevant now. How I did in high school does not matter. I went to a private college. I studied chemical engineering. My GPA and my major are relevant now. How I did on the MCAT has no bearing on anything going forward. I went to a state medical school. My grades, class rank, and step scores, no longer relevant. Nobody cares. They don't matter. My residency training was important, but where I went had little to no bearing on my future at this point, and that goes for my fellowship as well. So as an assistant professor of emergency medicine at UT Southwestern, how I do in the job that I have right now is what's going to be most important to whatever it is I'm interested in doing going forward, far more so than anything else that I've listed so far. And so keep that in mind for all the things that you're working towards, and remember to look at the big picture. The MCAT is important for sure in getting you into medical school, but it's not the end all be all. It's only going to matter until you get in. As far as my advice on choosing a medical school, choose the program where you think that you'll do the best. So going off of that earlier concept of how you did most recently being the thing that affects what you want to do next, doing well in med school is what's going to determine your ability to get into a good residency. So STEP scores, which you're likely familiar with by now, are the great equalizer. If you go to an Ivy League medical school, but your STEP score is not fantastic and you're at the bottom of your class, because most schools will report approximate class rank in the form of quintiles or quartiles, you won't do as well in the match. You're far better off going to a lower tier school and doing much better relative to your peers. Getting into that Ivy League medical school reflects how you did in college. And as we've already gone over, that won't matter anymore by the time you're applying to residency. Nobody cares how good you did in college when you're applying to residency. Similarly, your medical school debt will not be any smaller because it was accumulated at a higher ranked institution. So choose wisely. While that next step is important, remember that it's only as important as as far as getting you to the step after that, not something that's going to determine the rest of your life. So how did I get here? I did my medical school and residency at Rutgers, New Jersey Medical School in Newark, New Jersey. That's the picture on the right. It's a level 1 trauma center. It's very busy. It's very under-resourced. It's the kind of place where if the illumination of the U in the giant university hospital sign went out, it might get fixed in a few months to a year or never. It was a 4-year program. After I finished that, I did a fellowship in anesthesia critical care at Barnes Jewish Hospital in St. Louis, Missouri, or WashU is kind of the school that's attached to it. It's a very similar patient population, but way, way more resourced. They have a lot more money. If you notice in that picture, those tennis courts are owned by the hospital. So that is on hospital property. One of the letters in the giant Barnes Jewish Hospital sign did lose illumination while I was there, and it got fixed in like 2 days. And then while I was in St. Louis, I worked in a community ER as well. So just to give you guys a little bit of perspective, these were the 3 shows that I made time for in medical school. House to supplement my medical education, the Jersey Shore to stay true to my roots, and then The Walking Dead in case there was ever a zombie apocalypse. So just make sure you still have a life outside of medicine. So here's where I'm working now. I'm a full-time emergency medicine physician at UT Southwestern Medical Center, aka Clements University Hospital. That's the picture on the left, and then Parkland Hospital on the right. So Clements is a well-resourced institution with many patients who have advanced subspecialty care, as well as the socioeconomic privilege to support it. These are people with insurance who have very advanced therapies. They have left ventricular assist devices, and they have really terrible cancer that they've managed to survive this long, and they've had organ transplants. So to be able to do those things, you need to be privileged in some ways to support it. Parkland on the right is similar to where I trained in Newark. It's a very large, diverse, socioeconomically disadvantaged patient population, but Parkland has better resources than where I trained. So I get a nice mix. So how did I choose a specialty? I started off, I was an EMT back when I was in college, and that kind of gave me an intro into medicine. There was this idea, I didn't like the idea of not being able to, like somebody said that we need help, not knowing what to do and not being able to provide at least some assistance. And I learned very quickly after becoming an EMT that without an ambulance to bring me to a hospital, there's really not a lot that I can offer anyone. So when I started thinking about what residency I would do, I considered anesthesia. They do a lot of procedures. They know a lot about physiology. And when things are going poorly in the operating room, they're in charge. So surgery stops, anesthesiologist is the one running the show. However, a good day for them is a boring day. The patient goes under anesthesia, the surgery goes fine, the patient wakes up, not very interesting. I consider trauma surgery. They have a lot of interesting problems, a lot of procedures. The patient needs you right that moment. It's not like everything's scheduled. But I rotated on trauma for 6 weeks as a medical student, and the majority of patients these days don't need the operating room. They slipped and fell, they were in a car accident, they got assaulted. So by and large, if it's blunt trauma, it's managed non-operatively for the most part. And that's better for patients, but makes for a little less interesting of a lifestyle. Furthermore, being in the operating room didn't make up for all the time I spent rounding on the floor or seeing patients in clinic. And then as you may have heard, work-life balance for the surgery specialties and subspecialties can be pretty poor. So that left me with emergency medicine. First, you'll never see me in anything other than scrubs, which I do like. every day is different and interesting with novel problems. I shadowed in an ER for a day as a college student, and I saw one patient whose breast implant shifted to the other side of her chest, and we had to reduce it manually. And there was another gentleman with a new diagnosis of leukemia after he came in with persistent dental bleeding. You have to know a little bit about everything, which I like and kind of speaks to my personality. For the most part, there's very little to no patient continuity. Ideally, you see patients once and then never again. If you do see them again, either you missed something the first time or things just aren't going well for them. However, the upside is that you aren't often stuck with the same problem. And we'll get back to that phenomenon when we talk about critical care. I like having a working answer for almost all medical issues. If somebody actually needs something, I know where to start. I'll never be the doctor on the plane who hears the call for help and says, I'm not that kind of doctor. I also don't turn anyone away for lack of insurance, but it can have a real effect on my ability to connect them to care after they leave the ER. You have a lot of autonomy. You may be the only doctor in the ER or even in the whole hospital. You get the first crack at everything. It's also shift work. So this is fairly favorable as far as work-life balance goes. You do 8 to 12-hour shifts, or in some rural places, maybe 24 hours. I do 14 shifts a month, which leaves me with a lot of spare time. If you think about it, 16 days off, so about half the month. But somebody has to be in the ER overnight, on weekends, and on holidays. The stress can be high, and the burnout can be high, and the workload can be a bit overwhelming, and we do get sued fairly often. But if it suits your personality, I can't really think of a better field. So I did a 4-year residency in emergency medicine, and then I decided to do critical care. And so critical care kind of encompasses a lot of things, and we're going to talk a bit about what that means and what that career looks like. So first of all, who is a critical care patient? And the answer is probably not all of the people that you thought. So the way that hospital units are organized is by nurse staffing ratios. So when somebody comes into the ER and we determine they need to stay in the hospital for some reason, it's a question of how much care they need. And so there are 3 general levels in hospitals. There are floor patients, where the nursing ratio is approximately 1 nurse for every 4 to 8 patients. Then there's a PCU, or progressive care unit, maybe 1 nurse for every 3 or 4 patients. And then there's the ICU, which is 1 nurse for every 1 to 2 patients. And so if you think about it, if you have 1 nurse who's caring for 8 patients, that means that there are as few as 8 minutes per patient per hour. That's not a lot of time. And there's a lot of things that nurses have to do for patients. They need to check on them, chart their vitals, answer their call button, administer their medications, get them to whatever procedures that they're trying to get done that day, or any physical therapy they're trying to get done, make sure that they're fed. So if you're on the floor, you can't have a lot of urgent needs. That's not going to be a good place for you because you're not going to have a lot of attention. Whereas someone in the ICU who's on a blood pressure medication or is on some sort of therapy that could be life-threatening if it wasn't attended to quickly, you want somebody who's devoted to that patient. But that could also be somebody who just needs urgent attention or frequent attention. So for example, somebody could have had a surgery done by a plastic surgeon. Let's just say they had a burn or they had some injury. And so they had a skin flap done where they took a piece of skin from one part of their body and moved it to another part. Or maybe it was reconstruction after some sort of like breast cancer surgery or some sort of other cancer surgery. When they do those kind of transplants of tissue, they put a lot of work into it, and there's not a guarantee that it'll survive. And so they want it checked every hour for the first 24 hours. That patient may otherwise be very healthy, but because they need that flap checked so often, they need to be in an ICU, because otherwise that nurse is not going to be able to get to them every hour, and they won't have enough time to salvage that flap if something goes wrong. There are a lot of different kinds of ICUs and then a lot of different ICU models. So a hospital can have 1 ICU, it can have no ICUs, or it can have many ICUs. So in most places that have a low volume of sick patients, they'll have a single med-surg ICU. That means that it'll be a single ICU with a mix of medical and surgical patients. It'll be the ones who came in with heart failure and a really bad heart attack, and the ones who are septic, and the post-op patient, and that patient who had a flap who needs it checked every few hours, every hour. And that ICU will just take all the ICU level patients. In that case, you need a nursing staff that's comfortable with a wide range of patients and a matching intensivist. When you start getting to places with higher volumes, it makes more sense to kind of try and specialize. So these are the kind of different ICUs that a place can have. And I took this list mostly from where I did my fellowship. We had all all of these ICUs in one form or another. And so if you have an ICU that's devoted to burn patients, those nurses are going to be very good at doing dressing changes. They're going to be very good at doing pain control. Similarly, if you have the nurses in the neuro ICU are going to know how to monitor these neurosurgical patients. They're going to have very good neurologic exams. The ones in the cardiothoracic ICU are going to know what to look for and what to do if the ECMO machine isn't working, or if they have too much bleeding. The patients in the bone marrow transplant ICU are going to know how to handle all of those complications, signs of tumor lysis syndrome. And then the patients in the medical ICU are going to know how to do all the medical issues. And so it helps to specialize this for patient care because of nursing care. And then you can have an intensivist who also is kind of a specialist in these areas. Let's see. And then generally, for the most part, ICUs are divided into two types, medical and surgical. By and large, medical ICUs are staffed by doctors who did a critical care fellowship through medicine. They did, after medical school, an internal medicine residency, which was 3 years. And then they often did a pulm and critical care fellowship, which was another 3 years. Surgical ICUs are staffed by doctors, for the most part, who did a critical care fellowship through either anesthesia or surgery. And then neuro ICUs are most often staffed by neurologists, but there are other, if you're interested, you can get into one through one of those other pathways. So there are multiple paths to critical care, and also kind of depends on what kind of critical care you want to do. So option one, do an internal medicine or emergency medicine residency, which is either 3 or 4 years, and then do a fellowship in critical care through medicine, which is 2 years for emergency medicine and technically 2 years for internal medicine, but they all do 3 years to get that pulmonology fellowship as well. And then you're boarded through medicine. It is very easy for you to work in a medical ICU, or if it's ICU in the community somewhere, you could work in a mixed medical surgical ICU. If you do an anesthesia residency or an emergency medicine residency, you can do a fellowship in critical care through anesthesia. It's only 1 year if you do it through anesthesia, or if you did an anesthesia residency, it's 2 years if you did it through emergency medicine. In that case, you're going to be boarded through anesthesia. It's going to be easier for you to get a job in a surgical ICU of some kind, whether that's a cardiothoracic ICU, a surgical ICU, just a general surgical ICU. And again, you can work in some community ICU that has a mix of med-surg patients, but if you're going to work in if you're working in a place where the ICUs are specialized, it's going to be much easier for you to get into a surgical ICU than a medical ICU. Third pathway is through surgery. So you can do a surgery residency or an emergency medicine residency, and then do a fellowship in critical care through surgery. If you're a surgeon, it's only 1 year. If you're emergency medicine, it's 2. One of those years is spent doing a surgical internship. And then you'll be boarded in critical care through surgery. So similarly to anesthesia, will allow you to work in a surgical ICU of whatever kind. And then the last route is through neurology. Do either neurology or an emergency medicine residency, do a fellowship in critical care through neurology, which is 2 years for both groups, and you can be boarded in neurocritical care. And that will best position you to work in a neuro ICU. You may be able to get a job in one of those other ICUs, depending on their needs, but what your resume is going to look like is it sets you up to work in a neuro ICU. So emergency medicine can get boarded through any of those specialties, but it takes us 2 years after we finish our residency. That's the takeaway there. So what is the ICU like? And the answer is that it's much more of a team sport than the ER. In the ER, it's you as an attending, and then you have nurses, and for the most part, that's it. Depending on the ER you work in, there may or may not be a pharmacist, there may or may not be a social worker, but by and large, it's you, and most problems start and end with you. You may choose to get those other people involved, but it's not mandatory. In the ICU, it's a bit different. So you're going to have a team. You may have residents or fellows or advanced practice providers, or just yourself, depending on the volume of your ICU and what the practice structure is like. Generally, you'll have a pharmacist and a nutritionist and a respiratory therapist and a social worker working with you as well. The pharmacist is there to make sure that you're dosing medications appropriately, because these are complex care patients. And so they may have a lot of things interacting. Maybe they have renal failure and they're not clearing medications the same, and so their doses need to be adjusted. Maybe they have liver failure, same story. Maybe a medication won't work because it's metabolized through the liver and they're in liver failure. So, and then they also make sure that patients are getting fed and have enough nutrition because you need energy to be able to heal. So nutritionist helps with that. A and they can write orders, for example, tube feeding or TPN, which is total parenteral nutrition. So if somebody can't use their gut because they had a surgery or they're too sick, they're on really high blood pressure medications, then you may feed them intravenously. And that's actually really complicated. So you need a nutritionist to help you with those orders. Respiratory therapist. In the ICU, there are many patients who are either on ventilators or non-invasive ventilation. And so they'll round with you and tell you what they're seeing as far as secretions that are being produced, how they're doing on their breathing trials, are they ready to come off the ventilator or not. The social worker is really key because anybody who ends up in the ICU will leave it worse off than when they arrived. So especially in your elderly population, there is going to be a functional decline. And most patients don't go home from the ICU. They usually get downgraded to another unit in the hospital like the floor and eventually need to get rehab in some way, shape, or form, or get placed in a nursing home. And so the social worker is really integral to making sure that they have the resources available to support that care. And then they'll work with family members as well, because oftentimes it's a lot of decision-making that needs to be done. So physical therapy and occupational therapy may also be involved, but the team that you round with every morning, that's most of them. The general model, as far as what your day-to-day work is like, is to work a week at a time. So 1 week on, 1 week off, and 24 weeks or so is full-time out of the year. So I talked about my schedule, working 14 shifts a month and having half the month off. This is another way to do the same thing, but the weeks are going to be blocked. So that week can be either 12-hour shifts, days or nights, or you're on 24/7 for the entire week and you're just on call for any issues after you go home. Some people prefer one model versus the other. If you're on 24/7, you may get called in the middle of the night and you're still responsible for rounding on these patients the next day. At the same time, if you're doing 12-hour shifts, you're there at the hospital for that 12 hours, whether you like it or not. Whereas if you're on call, you can go home if there's nothing going on and just get called back. So generally you arrive at 7 o'clock, whether that's in the morning or at night, depending on your model. You get handoff from whoever was on overnight, and then you end up rounding on your patients. So generally I came in, I looked up everything from the night before, checked all the labs, went and saw everybody, and we started rounds by 9 a.m. And rounds essentially is going bed to bed, physically seeing the patient, discussing the plan with everybody involved. That's you, your team, as well as the nurses, and making sure that everybody's on the same page and that you know what you're going to do for the rest of the day. You may be interrupted for admissions or people who are decompensating. Medical ICUs get patient admissions at all hours because people get sick at all hours of the days and night. Whereas in the surgical ICUs, they mostly get their admissions in the afternoon because their cases start in the morning. So they'll start a 6 a.m. case. It won't get out until 1 o'clock or 2 o'clock. And then they get admitted to the ICU to kind of get them resuscitated and check on them until they're doing better, and then they get transferred out. When you're done rounding and taking care of whatever tasks you identified during rounds, you'll have family meetings, and then you're waiting around for admissions. So depending on how you operate, rounds can be super fast or super slow. So when I was in fellowship in the neuro ICU, rounds could go all day from 9 a.m. to 5 p.m. So, which they actually had a separate team to do procedures because you wouldn't have time to get any work done during the day. All the work would have to be done overnight since you spent all day rounding. Whereas in some other units, if the patient volume is low or you're really fast, you can get rounds done in an hour or two, and then you'll have a lot more downtime. So upsides of working in the ICU can include continuity of care. When you're on for a week at a time, you really get to know these patients, you get to know their families. There's a bit more ownership. And oftentimes, if you're on for a week, off for a week, on for a week, patients can be sick for a while. And so you may see the same patient several weeks at a time over the course of months. The other upside is having the luxury of time to think about and investigate problems. So in the ER, I spend only a few minutes with you. I have to get a general brief impression of what your problem is, figure out the best route to diagnosing you, and then what an appropriate therapy would be. All in the, and I only have a few hours to get this done because my shift is only 8 or 12 hours. And based on the number of patients in the waiting room, I have a lot less than that. In the ICU, you have hours, days, all week. So you can see how things progress over the course of time. You can sit there and think about these patients. You can go home and think about them because you're going to be back the next day. You can read about them. And so you can use that time when you're waiting for admissions or the things going on to kind of think harder about an individual patient. They get a lot more time from you. And so if that's something that you're interested in, it could be an upside. The downside includes,
So, Avi, this is Ray. When did you become a doctor? When did you become that person that when you were a kid and your mother took you to because you had something going on or something? When did you become a doctor and become that person?
I
You
mean, I
you
would say that nobody, a doctor, medical school does not a doctor make, so not until residency.
so the medical school does not a doctor make, and it was only into your residency training that you became a physician. Is that what you're saying?
Yes.
Interesting. And then, so when did you become a critical care guy? What was it that drove you toward that?
So I knew that I wanted to stay in academics, and I felt like coming out of residency, I wanted to bring something more to the table than just being a residency trained ER doctor with not a lot of real world experience other than my residency training. And so of the fellowships that were available to me in emergency medicine, I felt like critical care would add the most value to my practice, was most in line with my interests and values, and then was pretty much one of the more prestigious fellowships that I could do. It's definitely known as being one of the harder fellowships to do. So coming from emergency medicine, where you work X number of shifts a month with a lot of time off and fellowship, it was roughly 65 hours a week and many months of the year. So I had 7 months in a row without a break. It was very painful.
So
you
it's
see
the
a lot of patients.
it's the sickest people in the world, obviously, being admitted to critical care from the ED. Has your path kept up with that? That's what you want to do, and you continue to move that direction?
So ultimately, for me, it ended up being an issue of work-life balance. So I would prefer to work 8 hours a day, whatever those 8 hours are, have time to work out, spend time with my fiance, make dinner, go run errands and do things and have a life, even if I work 4 days a week, every week. Compare that to the ICU. If I do 12 hours at a time for a week in a row, that week is gone. I get to work at 7 a.m. That means I woke up at 6. I'm not home till 8 p.m. You have time to do one thing. That can be working out, that can be making food, that can be spending time with your significant other, but that week is shot. You have to be in bed pretty early because you're back up at 6 in the morning. And so even if I have that week off, I'd much rather have a usable part of my day every day than 1 week where I cram all these things in. If you think about, what you need to do, you can't just ask somebody to cover a day for you in the ICU. You need to switch weeks. Whereas in the ER, if I have an event I want to go to, my kid's soccer game, a dinner I want to attend, I want to go out of town, I can either move my shift from a 7 a.m. to 3 p.m. shift to a 3 p.m. to 11 p.m. shift, and I can get the morning off, or I can ask somebody to pick up that shift, and it's not a big deal. So you have less flexibility in the ICU. And that was ultimately kind of the biggest issue for me.
So you're talking about shift work, and you've got 200 future physicians listening to you right now, Avi. So is shift work sort of the way of the future for all these soon-to-be docs and nurses and NPs and so forth?
I think that depends on who employs you and how your field works. So anesthesia can do shift work because they feel like they're somewhat interchangeable in the OR. You can give handoff and somebody else can take over that case. And that's what has to happen if it's a really long case. That will likely never be the case with surgery. Nobody is going to swap in the middle of a procedure in the operating room. So I don't see that happening for them. There are a lot of physicians that are clinic-based. And so I wouldn't necessarily say that that's shift work, but it is a set schedule. You decide what your clinic hours are and you decide how much time you're going to put in beyond that, whether you're answering patient emails and calls after hours, or whether you're taking call for your practice or for a hospital. I do think that shift work affords the best work-life balance, but if you own your own practice and you set your own hours and decide you only want to work 3 days a week and you can cancel a day if you feel like it, then that may be even more advantageous. But compared to the traditional model of medicine, I think shift work is an improvement.
It's interesting, Avi, that most physicians today are actually employed. They are not contractors. They are not working on their own. They're actually employed by a company somewhere. And so you're an employee. How do you like being an employee, being a shift worker in a large urban ER setting? How do you like being an employee?
I will say that I'm a fan. It's less complicated. You have a salary, you do the work. They may or may not include incentives, but I guess I like knowing what's expected of me because somebody else is setting those expectations. The other side of it is if you're your own boss, you have the potential to make a lot more money, but you're also going to probably put a lot more time into it. So it doesn't really make much difference to me whether UT Southwestern expands, whether their ER grows, whether they see more patients. In contrast, if I ran my own dermatology practice, I may want to hire more PAs and NPs. I want to market. I want to get more patients in the door. I want to figure out how I can see them more cheaply and yet bill more money for the things I'm doing for them.
Right.
And so it adds a whole other level of stress.
All right. So for the listeners tonight, and there's over 200 that are listening right now, Avi, down the road, you're either going to be an employee or you're going to be working on your own with your own company. Most physicians today are actually employees. That's a change from the last many years, that in fact physicians tend to work for other companies as opposed to be on their own. And so what I would just conclude, Avi, is that for the listeners tonight, is that as they look forward to what their future is going to be, is that chances are they are probably going to be an employee of a company. Would you agree with that?
Yes.
Well, please keep going. I'm sorry to interrupt. Please keep going.
No. So the downsides of critical care include patients that you can't fix. And so we had a patient when I was in the ICU in fellowship who was in and out of that ICU for at least 6 months. He had a surgery to take out a cancer near his pancreas. It wasn't totally successful. And so he ended up with a very large hole in his abdomen. And you could, every time you took his dressings off, you could see his liver, and he kept bleeding. And so he would bleed overnight, and he would have to get large amounts of blood products to save his life. And he would end up going to the interventional radiology suite where they would try and plug whatever's bleeding. And they eventually said, there's nothing left. If we plug any more, we're going to cut off blood supply to things he really needs. And so we had a discussion with the family, and we had to talk with the surgeons as well. And the surgeons felt like he had a really good chance to pull through. And so we did. And it took him 6 months of having these bleeding episodes. At one point, he was in the ICU only because he needed ketamine, which is a sedative agent, in order to do his dressing changes because it was so painful. And so you can't do that in a non-monitored setting. And so that was a reason why he was in the ICU, even though his blood pressure was stable and he really didn't have any other needs. And so after 6 months, he finally said, that's it, I'm done. I don't want any more blood transfusions. Initially, he had said he wanted to die. And then we said, well, you must be depressed. And so we'll put you on an antidepressant. We don't believe you. There's no way that you want to give up. And so 6 months later, we finally decided to believe him. He said, no more blood transfusions. And we said, okay. And then he eventually passed away because of another bleeding episode. And so it can be frustrating dealing with patients who aren't getting better, and especially patients that you don't have either the ability or the autonomy to fix. So if you work in a surgical ICU, you need to co-manage the patients with the surgeons, and they feel like appropriately that they own these patients, they operate on them. Ultimately, they feel responsible for their outcome. And so sometimes they may want you to do things based on their experience that may not be consistent with your understanding of medicine or the way that you practice. So in fellowship, I used to joke that if I was supposed to give if somebody asked me what fluid I should give a given patient, my next question would be, what ICU am I in and which attending am I working with? Because in the neuro ICU, the answer is going to be normal saline or hypertonic saline. In the medical ICU, it'll be lactated ringers. In the cardiothoracic ICU, it'll either be blood, albumin, or Lasix. And so even though you would think that all patients are human, and so the same medicine, like the same principles of medicine would apply, it varies based on the experience of the people working in each of these places. In the cardiothoracic ICU, you're working with cardiothoracic surgeons, and they feel strongly about keeping somebody's hemoglobin above a certain level. And so whether you believe in evidence or not, ultimately it's their patient, and you need to come to terms with the fact that you need to play nice with others, and you are helping them with their patient, but they're not ultimately yours. In contrast to the medical ICU, where there really isn't anyone else who owns the patient, you can do what you feel like is best with a bit more autonomy. So that is one downside, but there may be patients who you feel like need to have a goals of care discussion, that you're prolonging life without any quality, and families may not be comfortable with that. And so you may be stuck with a patient where you come back every day, you've made no progress, and you feel like you're not doing what's in their best interest, but your hands are somewhat tied because family is not on board with withdrawing care. And at least in this country, we have a culture of prolonging life kind of at any end, or to any extent. And then we talked about work-life balance being a pro or a con, depending on your personal preferences.
So, Avi, is that why you approached medicine? Was it that you could do shift work? Is that you would be able to control going in as you started to study, that you would get into a part of medicine that you would be able to do shift work and control your shifts? Was that part of the deal going in?
No. When I decided to go into medicine, I was young, thought I had all the time in the world, and that I did not value my time especially highly. I was singularly focused on a field that I found interesting and rewarding, regardless of the kind of time that I would have to put into it.
So what brought you to emergency medicine, Avi? There were so many things. I mean, you're so freaking smart. You could have done all kinds of things. You could have been the hospitalist or whatever, but why emergency medicine? And then as a subset, why critical care? What brought you to that?
So emergency medicine, I like knowing a little bit about everything, and we have to know a little bit about all fields. I like knowing what to do when things are really kind of critical. So having a working answer. If somebody calls for help somewhere, I at least know where to start. I'm not going to sit there and say, well, I'm not that kind of doctor. There's a good number of procedures in emergency medicine, which keeps it interesting. We do some interesting stuff. I don't have to deal with follow-up or complications. If you're a trauma surgeon, you operate on somebody, you operate on them once, and you'll see them in clinic for follow-up multiple times after that. And that is, to me, not nearly as rewarding as the original procedure. And I feel like in emergency medicine, the patients actually need you. And not that they don't need you in another field, but somebody may need a cardiologist, they need a cardiology appointment. That is not something that's time sensitive. They need some cardiologist someday. But when someone shows up in the ER, whether they really need you or not, they think they do. And that's enough for me to kind of motivate me. And then
so Avi, do you feel like in emergency medicine that you have to be really good at all fields, electrocardiography, radiology, surgery, and so forth? Do you feel like that you actually have to be really, really good in those fields?
I mean, I'll never be as good as any of those specialists are in their field. I like knowing the important stuff and kind of when I need their help. So you can't reproduce all of their residencies at once. And there are things that I'm never going to know about each of those fields, and I'm comfortable with that. So you also have to be comfortable knowing that you aren't going to be an expert in any of those things, but you can kind of be an expert in the undifferentiated everything.
Yeah, I found in emergency medicine that if you looked up everything that you don't know, I mean, you know what I mean? It said, my God, there's so much stuff that we see every single day and all this wide range of patients that if we were to look up everything we don't know, my God, we would be such great doctors. It's a real challenge. Okay, I'm going to quit babbling. Taylor, you got some questions for us, right?
Yes, I do. One of the questions that we have is, so how do you keep your mental health strong while working in this field? You said sometimes patients maybe aren't getting better over time, or maybe you go in one day and you feel like you don't know anything. Like it's like Dr. Fowler just said, you just keep seeing a bunch of patients where but it's not something that makes you feel competent in what this person has, or just what would be the most difficult thing to deal with, and how do you keep your mental health strong?
I don't think that's a question that's unique to medicine. I think that medicine can make you question it a bit more or put some more stress on you because you're challenged that way. But you could go into a field and be promoted to a management position at some company and not know how to address the issues that you're faced with and have the same kind of stress. So I think that's something you need to build up regardless of what field you go into. And that's going to be different for everybody. Some people that's going to be, reading these, looking at Instagram posts with kind of self-affirming statements, things that kind of motivate you or make you feel good about yourself. Some people it's going to be compartmentalizing or decompressing. Some people get it out through exercise. So I don't think there's one answer that kind of suits everybody, but I do think that it's an important skill regardless of the field that you go into. There will be shifts that are better than others. There are some shifts where I come home and I feel like I did an absolutely great job. I went above and beyond, or I knew things that other people didn't, may not have known. I did, and I was efficient. Like that to me is actually a personal, it brings me joy to feel like I was more efficient than other people. I was able to get to a diagnosis with fewer tests, or I didn't need to do as much of a workup, or I was able to efficiently get somebody to the care that they need. And there are going to be shifts where you come home and say, you know what, that really was not the best. There were a lot of things that weren't rewarding. I had unhappy patients that I couldn't help, or I had confusing patients that I'm not sure I did the right thing on. But the nice thing about emergency medicine is that the patient can't generally hurt you more than once. So that was a little more frustrating in doing critical care, where you come home and you're like, I still don't know what's wrong with this patient. They're sick. I'm not sure how to fix them. I don't know what I'm missing. And you come back the next day and they're still the same way. Or you're like, you know what? I can't get them off of the ventilator. I don't know what else I can do to make them better. And they're just not getting better. Whereas in the ER, no matter how bad it is, you will go home at the end of those hours and you likely will not see that person again. And you won't be faced with the same issue and you can start fresh. So I think that actually in that sense, emergency medicine in itself is kind of a coping mechanism because it will end. There is a set time that you just need to make it to, and it will be over.
So Avi, do you take cases home with you sometimes? I had a 27-year-old guy with COVID that died in front of me, and we worked his code and couldn't get him back. And do you have cases that you take home with you and you cry all the way home sometimes?
There are mistakes I've made that I definitely take with me.
Well,
I don't always know.
I'd say it was mistakes, but shit happens,
I write patients down and I follow up on things that I find interesting. But I guess when I was rotating through emergency medicine as a medical student, there was somebody who came in screaming with chest pain, and the attending, I thought that was really interesting. The attending is like, this is nothing. There's nothing to be excited about here. He's young, he has no risk factors, he's histrionic. This likely, there's nothing wrong with this guy. And so I asked him what did scare him. And he said, when a patient comes in, if somebody comes in coding, that's not as concerning. They were already dead before they arrived. But if somebody came in talking and then they coded in front of you, it makes you wonder what you missed and what you could have done differently. And all of a sudden you feel like it's on you to reverse that process. Whereas if that person had coded 5 minutes before coming in, you wouldn't feel the same way.
There was a television series called MASH, which was about the Ford surgical treatment in Korea. And there was a scene in there where Hawkeye, who was a surgeon, he had a patient come in who was all shot up, and he took him to the operating room and operated on him, and the guy died. And after that, Hawkeye was sobbing, and the priest came to Hawkeye and said, "What is this?" And Hawkeye says, "I have never had a person come in who was alive that I was not able to save. And I am just destroyed and sobbing because of this." And the priest said, who do you think you are, God, that you can save everybody? Who do you think you are? And so Avi, can you save everybody or no?
Oh, most definitely not. But that's something you need to come to terms with.
Absolutely. Taylor, what you got?
Okay, so this one's kind of unrelated to the previous question, but what kind of experiences and like research or activities did you do to like enhance your application for residency? Do you feel like that there's a lot more that you could have done, or do you feel like it's not too rigorous in terms of like what you need to have to be able to get into, I guess, emergency medicine residency?
I think that if you apply widely enough, you will find an emergency medicine position somewhere. I felt like I killed it for applying to residency. I got interviews almost everywhere I was looking at. So having a high step score is going to help. Doing well is going to help. And mostly they screen by those things. There are fields where if you don't do research, you're really looking behind, and like people are not going to judge you as favorably. But in emergency medicine, we're not a research heavy field. And so you can get publications and we might say, oh, that's interesting. But having sat in a bunch of residency meetings, we have never decided to rank somebody more highly based on the research that they've done. And you need to think, and this is a really important concept that I didn't learn until I was applying for jobs after fellowship, is that you need to think about the needs of the person hiring you when you're applying. What you think is important and what they think are important may not be the same things. And so there was a candidate that I had seen in one of the residency meetings who actually had done a ton of research. They were clearly going to be a big name, whatever field that they went into. They wanted to invent products. They were somebody who was going to do great things. There was no question. And the residency program director said, I actually don't want to rank this person at all. They may do really great things, and that's nice, but they're going to be a real hassle to train. They're always going to be focusing on some of these projects, and they're going to take time away from other residents. They are, I'm going to need to rein them in, get them focused back on track. They're not going to be working on the things that I want them to work on. They're going to be working on their side projects and all their ambitions, and that's great, but that's not what I want to deal with. And so that's somebody who felt really strongly about going to that particular program, and they weren't even ranked. And they had a great resume. And so you need to think about kind of what the people that you're applying to are looking for. And the answer is not research. You want to do research, by all means. It looks nice on a CV, but nobody's making a decision about whether or not they want to work with you and hire you based on the research that you did. So I got to know the people that I was working with. I think that getting to know the emergency medicine faculty early is beneficial so that they can write you kind of stronger letters, and they have a bigger basis of information to write that letter on. At the same time, that can backfire if you're somebody that has some adverse personality traits that can work to your disadvantage if more people know about them. So perfect is the enemy of good. If I listen to you.
So Avi, we had a nice question from Danielle that says, what is your advice on how to get the most out of your emergency medicine clerkship? Can you comment, please?
Well, definitely read a bunch beforehand and try and take as much ownership as you can. I would say look for rotations that give you autonomy. So I did 4 emergency medicine rotations as a medical student between my 3rd and 4th year. The first one was at a local hospital system. The second one was my home institution. The third one was in another city. And the fourth one was also another city. But my 3rd rotation, I functioned as an intern. I wrote notes. If I discharged a patient, they disappeared. If I ordered blood, it showed up. And so having that kind of responsibility was a huge wake-up call. All of a sudden, I get this EKG and somebody has chest pain. I'm like, do I order the aspirin or do I wait? And so there was always an attending to go talk with, but when they were busy, I had to make some decisions, on the early side on my own. And that was that made me grow up a lot faster. So I think that if you want to get the most out of your rotation, find a rotation that gives you autonomy where it forces you to step up to the plate. If you're just going and doing H&Ps and presenting it to your resident or attending, and they're writing the note and they're putting in the orders, and ultimately you're kind of just redundant, that's not going to give you the same experience.
So Avi, how does the first 2 years of medical school prepare you for seeing patients? The first 2 years?
I guess it teaches you how to do a complete history and physical, but I think that what the second half of medical school and what residency does is give you the context to know what to ask. So they teach you about the different components of pain, how long it's been going on for, what makes it better or worse, does it radiate or not radiate. But there's a difference between asking those questions and then having the context to say, oh, chest pain that radiates increases your risk of a heart attack. Or, oh, pain after eating means that you likely have an issue with your gallbladder or pancreas. So having the clinical context for those questions is important. And so I think that you kind of have some building blocks.
It takes a long time, doesn't it?
Yeah. I will say that when I shadowed or rotated through the ER there was a shadowing program as a first-year medical student, having just taken anatomy, I was much better at dealing with musculoskeletal complaints than the residents were, because that was the only thing I did and it was all I knew. I was very, I knew everything there was to know about the shoulder joint. And so I could figure out if somebody had a rotator cuff injury or not, or if they had, some sort of tendonitis, because that was all I knew, which also meant that that's all I'm looking for. So, but I was not going to be very good at diagnosing anything else.
Okay, Avi, so we've been going almost an hour. Do you need to get a sip of water or go pee or anything physiological or anything? You okay?
Yep, I think we're okay.
Okay. Well, rock and roll. Take it to the next phase, would you?
All right. So we have 3 cases to talk about. The first one is a case that I saw not too long ago at Parkland. So it's a 25-year-old gentleman. He's coming into the ER by EMS. He hasn't been at work in 3 days. Apparently, he's been calling out of work complaining of a headache. And so somebody called EMS saying that they wanted, they hadn't heard from him. They wanted him checked on. And so when EMS got to his house, they found that he was confused. And so they brought him to the hospital. His vital signs were only significant for tachycardia, which means an elevated heart rate. He couldn't provide much of a history. So he has an expressive aphasia. He is unable to speak. It seems like he understands you and he can nod appropriately and follow commands. You can ask him, is this a new problem for you? And he can shake his head and you can say, have you ever had this problem before? And he'll shake his head no. And you say, do you know what you want to say, but you're not able to get it out? And he'll say yes, but he's not able to get any words out. When you examine him, for the most part, it's benign except for his expressive aphasia. And then he has bloodshot eyes, but neurologically, otherwise intact. He can his coordination seems okay. His strength seems okay. But he just has this expressive aphasia. And so when he first came in, the differential for me was, this is something that's wrong with his brain. He must have a stroke. And so when we think about stroke, there are some therapies that are time dependent, namely thrombolytics. And so there's this thing called a door to needle time. And this is tracked as a quality measure, so it's a big deal. But the last time that anyone had seen this guy acting normally was 3 days ago. So he's outside of the window for time-dependent therapies, which means that I don't need to activate these processes that involve all these consultants and get all these things done right away. We have time because whatever damage is there has been done. And so what I was thinking about is, could he have a bleed in his brain? Could he have a tumor in his brain? Or could he have a blood clot in his brain? And so as I put in some orders, I call neurology right off the bat because I feel like this has to be a stroke of some kind. They're going to need to get involved. I might as well accelerate that process. And so they come down and come see him. And while they're in the room with him, the nurse pulls me aside and says, I just overheard the family talking about how they have a carbon monoxide issue in that apartment building. And that was something I hadn't thought of. And so I end up sending the carbon monoxide level that comes back at 37%. And so if you are a normal person, your level should be 0%. If you're a normal person who smokes, your level might be up to 5%, but 37%, way beyond normal. So carbon monoxide is a colorless, odorless gas that's produced as a byproduct of combustion. So most often you'll see people get exposed to this through car exhausts, as a byproduct of fires. Maybe they have a generator. So especially in that cold snap that Texas had, some people brought generators inside their house and ran them for heat. But the issue is that they're meant to be used outside where the exhaust can kind of dissipate. And when you have an enclosed environment, that exhaust is producing carbon monoxide, which builds up, and you really don't know. So what does carbon monoxide do? So hemoglobin is a molecule in your blood that carries oxygen to tissues. Oxygen binds to hemoglobin, and then when the hemoglobin gets out into your tissues, oxygen disassociates from hemoglobin and gets absorbed by the tissues. So carbon monoxide actually binds to hemoglobin better than oxygen does, and it displaces it. A pulse oximeter, which is that thing we put on your finger to measure your oxygen levels, appears to have normal values because it just looks at how saturated the hemoglobin is. And the hemoglobin is fully saturated, but with the wrong molecule. It's saturated with carbon monoxide rather than oxygen. So you can only detect it with co-oximetry, which is basically a special type of pulse oximeter that specifically looks for carbon monoxide. So kind of the classic presentation is a whole family comes into the ER who develops headaches, including the dog. Or maybe they'll say that, we have it over when we wake up in the morning, but over the course of the day after we've left the house and gone about, it gets better, but it comes back at night and in the morning. So I've never seen it present with stroke-like symptoms. The solution is to supply as much oxygen to the patient as possible. So the way that we talk about kind of drug levels in the body is with respect to half-lives, and the half-life is how long it takes for the level to drop by half. And so different things are drop in different fashions. So there can be a linear clearance where, the amount that you lose in an hour is let's just say you start at 100 and after 1 hour you get to 80, after the next hour you get to 60, the next hour you get to 40. So that's linear. You can also have a logarithmic decrease, and whereas hour 1 you get to 50, and then hour 2 you get to 25, and hour 3 you get to 12.5. So that's the way that a lot of things clear, including carbon monoxide. So by increasing the amount of oxygen that the patient breathes in, you can actually decrease the half-life. And so, while it might take them 8 hours to clear carbon monoxide if they're just breathing room air with 21% oxygen, if you give them a face mask where they're breathing 100% oxygen, that may go down to 4 hours. And if you put them in a hyperbaric chamber where you can increase the amount of oxygen that they're getting by putting them at several atmospheres of pressure, then you can decrease that to maybe 30 minutes. So, so we actually immediately put this gentleman on a face mask of oxygen, and then we started looking for a place we could transfer him where he could get hyperbaric therapy. That was actually harder than we thought. So there aren't that many hyperbaric chambers around. They're kind of expensive to maintain. They're generally money makers for hospitals. They use them for wound care. So this thought being that if you have poor perfusion because of bad blood supply to an area that's infected, putting you in a hyperbaric chamber where you can increase atmospheric pressure will increase the amount of oxygen that gets to those tissues, and so they'll heal better. But to do that, they don't need a giant hyperbaric oxygen chamber. They just need one big enough to fit an arm or a leg. And so finding one that had a hyperbaric chamber that a human could fit into and that was available was actually really difficult. There's only only a few in the Dallas area, and we had some trouble finding one to transfer him to. But in the meantime, his symptoms started to improve in the ER with the oxygen therapy. He started to regain his ability to speak. And so we transferred him out if we found a place for him to go. So the moral of the story is that emergency medicine can also be a team sport. We had neurology involved. I had to work with the EMS system to try and find a place to transfer him to. I needed an accepting physician at that other facility that would take him for hyperbaric oxygen therapy. The indications for using hyperbaric oxygen therapy is either if you're pregnant because we worry about what this can do to the fetus, or if your levels are over 20%, or you have some sort of neurologic dysfunction, such as you passed out, or in this case, stroke-like symptoms. So the best thing you can do to protect yourself is to have a carbon monoxide detector at home, and then make sure that anything that is producing carbon monoxide is well ventilated. So don't run your internal combustion engine car in a closed garage. That will not be good for you. Don't bring a generator inside the house if it doesn't have a way to vent inside.
All right, so Avi, the approach to the patient with altered mental status then has to include, among other things, thinking about carbon monoxide intoxication. Is that correct?
It does. It was kind of surprising because it was, it was warm weather. There was no reason. I still to this day don't know why the carbon monoxide levels were so elevated in that apartment building. It's something to think about, and that can be one of the challenges in emergency medicine is the number of problems that people have can be infinite. And so not only do you have to know about all of them, but you have to think of them on the spot. And so had the nurse not given me that clue that the family was talking about issues with carbon monoxide at the apartment building, I would have had no idea that was this guy's problem. I just wouldn't have thought about it. He wasn't telling me he had a headache. He couldn't say anything at all. And he eventually would have gotten better, but he was able to get better faster because we were able to give him oxygen and send him to a place where he had hyperbaric therapy.
All right, Avi. So you just said something. You said you said that in emergency medicine that the things that people could have could be infinite. So how do we do that? I mean, we're doctors, we're humans. I mean, how in God's name do we approach the infinite when it could be anything?
Well, from an emergency medicine standpoint, I feel like my responsibility is to keep the patient alive and rule out the stuff that can't wait. So in an ideal world, and what I tell patients is that we're good at stuff that's really easy to fix and really dangerous. And there's a lot of people that fall into a middle ground. If you come into the ER and you have breast cancer, I'm not a breast surgeon. I don't do biopsies. I don't do surgeries. I don't do chemotherapy. It doesn't mean you don't have a problem, but I'm not the person to deal with it. And I'm okay with that because I can get you in to see a breast surgeon. I can get you in to see an oncologist, and that's not time sensitive. And so I focus on the stuff that really is important that either can be fixed really immediately or needs to be fixed immediately. And that's where I focus my efforts. And I'm okay with the fact that I may not figure out what's going on with everybody, but I'll come up with a plan to get it figured out. I can send them to a doctor who has more time than I do, more experience than I do, and more resources available to them to kind of figure this out in the long run.
You know, where I start, just from an old man, you know, what I start is that can I kind of see if I can figure out if the patient is having an emergency or not? Is it something respiratory or airway or circulatory or something that I can determine whether it's tachycardia or diaphoresis or whatever, air hunger or whatever, that seems like physically that they're actually having an emergency. And do you think that that's a reasonable way to approach our field? Is the patient having an emergency or not, Avi?
I mean, I think that's a reasonable place to start. A lot of people aren't actually having an emergency. And so my next best goal is to see if there's something I can help or fix in the short term. And so either way that you start with, I think it's a good idea to start with ruling out the emergencies because that's our ultimate goal, is to keep everybody alive. And if I miss something that was easy to fix but not time sensitive, it's not the end of the world. It's only a bonus if I'm able to do something more for the patient beyond that.
Wonderful. Taylor, maybe one more, and then we'll go back and let him move on.
More questions? Is that what you're saying?
Maybe one more. Do you have one more?
Yeah, I can see. So one of the questions kind of relating to COVID is, with the ICUs being at capacity, how has COVID affected like your day-to-day activities and what you're able to do for patients?
Well, that's challenging. So I think that it's somewhat dependent on, there's a lot of context involved. So I had friends on the East Coast when the initial COVID surge happened who had patients that were boarding in the ER, meaning that there was no room for them upstairs, and so they were dying in the emergency room. I haven't experienced that here. What happens is if there's not enough beds for patients to be seen in because everybody's waiting to go upstairs or waiting for an inpatient bed, the waiting room backs up. Your honestly day slows down because you're not seeing as many patients. Things that may otherwise be admitted have to be sent home because there's no room for them. Let's just say somebody comes in with rectal bleeding and they have a hemoglobin that's okay. So in the old world pre-COVID, that patient may have been admitted for a colonoscopy. But if your hospital is full of COVID patients, they're going to say, you know what, we don't have room for that. The patient's hemodynamically stable. They're not, their hemoglobin's okay. This bleeding is not life-threatening right now. And so we have to send them home so that they can follow up somewhere else. We're seeing a good number of people whose care is getting delayed because they can't get that elective surgery or semi-elective surgery because there's no room in the hospital for them after they get out of the operating room. Or they're not getting the care that they otherwise should be getting. They're not getting their screening, colonoscopies, and other exams because everybody's backed up or there's no room. And so there's kind of big overall system effects, but on a day-to-day basis, we also were overwhelmed pre-COVID. I mean, now we're overwhelmed with different things. So we always had people holding in the ER. It's not especially different, at least at this stage of the pandemic.
Gotcha. Okay, well, that makes sense. Do you think that that'll have affect in the future? Like more people will come in with all of these issues that they weren't able to deal with at the time, or like they thought they couldn't get into the hospital, so they didn't go. And then,
I mean, there were a lot of people who pre-COVID who didn't get care because they weren't able to for one reason or another, couldn't afford it, didn't have the time, couldn't get off work. I think that eventually COVID is going to just be a part of our lives. And so we'll see some COVID patients, but everything's going to get back to roughly normal as far as efficiency goes and the amount of healthcare that we're delivering to people. I think we get there faster if more people got vaccinated, but we'll get there eventually.
okay, well, you're welcome to continue unless Dr. Fowler has something to say.
No, please, Avi, go ahead.
Okay, so case number 2, this is a woman in her mid-30s. So she was found unresponsive at home. The boyfriend is there with her in the ER and tells us that she has a history of depression and pseudo-seizures and alcohol abuse. Per EMS, they said that when they arrived, she was unresponsive, covered in vomit, hypoxic with low oxygen levels, and they did a finger stick for her blood glucose, and it was 400. And normal blood sugars should be generally less than 120 to 150 if you don't have diabetes. And the boyfriend adamantly denied that she had any history of diabetes, was not taking any medication, had never been diagnosed with it previously. So we initially get her onto the bed and take a look at her, and she has a normal temperature. She's breathing pretty fast. She has a normal blood pressure. Her heart rate's going a little fast. And she's actually, we put her on a face mask and her oxygen level is okay with a little bit of supplemental oxygen. So we go to examine her and she's not responding to us at all, but her eyes are open. She's making pincer movements with both hands. She's pooped on herself. And she's covered in bruises in various stages of healing on her chest, her back, her arms, her thighs, and her groin area. So you can tell that these weren't all accumulated at the same time because they're in various stages of healing. So we talked a little bit more about the boyfriend. We asked him where all these bruises came from. And he says that she's been having panic attacks the last few weeks. And when she has them, she asks him to grab her and squeeze her to help abort them, and thus the bruises. So that was the only corroboration we could get. He seemed fairly reliable, but he was adamant that she didn't have diabetes, or really any actual medical problems, just some psychiatric issues. So what's going on? She's altered. Long list of things that can cause that. Did she have a stroke? Maybe. Did she overdose on something with her history of depression? Maybe. Is she intoxicated with her alcohol abuse? Possibly. Did she have a seizure? Is that why she pooped on herself? Is that why her hands keep moving the way that they are? Is that why she's unresponsive? Her blood sugar is elevated. So kind of one of the emergent conditions that we worry about in that case is diabetic ketoacidosis, where your body isn't producing, or your body isn't responding to insulin. And so you start trying to digest yourself for the most part. And then why is her oxygen levels low? We have her doing okay on some supplemental oxygen, but per the EMS team, her oxygen levels were low and she was just breathing room air. And so does she have a blood clot? Is she just not breathing enough, even though she looks like she's breathing quickly? Does she have something wrong with her lungs, like pulmonary edema or COVID, that's causing her to not have a good oxygen saturation? So really, this is undifferentiated. And so we basically just throw everything at her. We get a whole bunch of labs. We decide we're going to get a CT scan of her head, and things start coming back and they are not looking good. So we get a venous blood gas right off the bat, and her pH is 6.72. So a normal pH is 7.4. A normal range is 7.35 to 7.45. She is so far off, it's dangerous. Her bicarbonate is only 8, and normal is about 24. Call it 22 to 26 is a normal range. So she has a metabolic acidosis. And then on top of that, her partial pressure of carbon dioxide is 65. So normal is around 40. This tells you that she's retaining carbon dioxide. She's not breathing it off, even though she's breathing fast. And so she has a mixed respiratory and metabolic acidosis. We get a CBC, complete blood count on her, and her white blood cell count is low, 1.9. Now, traditionally, when you're screening for sepsis or bacterial infection, we consider either an elevated white blood cell count or a depressed white blood cell count to equally be indicative of bacterial infection. So now we're worried she has an infection somewhere. Her hemoglobin is a little bit low, 11.4, but women also run a little bit low. But her platelet count is 54. That's very low. So a normal platelet count is 350 to 450,000, and she's at 54,000. So We get her chemistries back. The relevant things is that her glucose is 495, which makes no sense in somebody without diabetes. Her sodium is 117, which, so sodium levels are affected by glucose levels. The higher your glucose is, it dilutes your sodium. So her actual sodium was probably 125, and even that is still pretty low. Her bicarbonate level is 4. This is a better test than the one we got on the venous blood gas, so she's even sicker than we first thought, which is still pretty sick. And then her creatinine level is 2.3. So creatinine is a measure of kidney function. The better your kidneys work, the more creatinine you're able to pee out, and it doesn't accumulate. When your kidneys stop working, your creatinine level rises because you can't excrete it. So, so far we're acidotic. We are thrombocytopenic with a low platelet count. We're in what looks like acute kidney injury, if not renal failure, and our glucose is super high. Her liver function tests are abnormal. She has elevated AST, which is one of the liver enzymes, but her ALT is normal. And her bilirubin is elevated at 3.0, so it looks like she may be going into liver failure. Her lipase, which is an enzyme in the pancreas, is over 3,000. So that gets released when, basically the way that we measure chemicals in the body, imagine every organ holds onto a given chemical, and when it gets injured, it leaks out, and then we can measure how much is leaked out. And so for her lipase to be over 3,000 tells us there's something very wrong with her pancreas. Her ammonia level is 160. Ammonia is a chemical that's cleared by the liver, and so when you start going into liver failure, your ammonia level will build up, and that will make you very confused. So that was another explanation potentially for her altered mental status. Her lactate was 18.4. So lactate is kind of a measure of anaerobic metabolism. If you have enough oxygen getting to your tissues, the way that you metabolize it, you don't produce lactate. But when you start running out of oxygen, you go into an alternative metabolic pathway that produces lactic acid. For example, if you guys are running, doing a marathon, your muscles require more oxygen than you're supplying, and so they start generating lactic acid as a byproduct of an alternative metabolism. So she's not running a marathon, but she's really sick. She's not getting enough oxygen to her tissues, and she's generating a lactate that is very, very high. So we start getting worried when that level is above 2.2, and she's at 18. Beta-hydroxybutyrate is a chemical that is a byproduct. So basically, if you're not able to metabolize glucose because you have diabetes, then you'll start metabolizing other things. And so beta-hydroxybutyrate is a marker for those other things, and it tells us that she is not metabolizing glucose. She has some sort of insulin deficiency. And then we were worried about overdoses and intoxication, and her Tylenol level, her aspirin level, and her alcohol level was all negative. So what happened here? And ultimately what happened was she had been drinking so much that she fried her pancreas with alcohol. So the two most common, there are three common causes for acute pancreatitis or inflammation of the pancreas. The first is gallstones, the second is alcohol, and the third is medical intervention. So somebody who gets a procedure done to relieve gallstones, you can end up inflaming the pancreas. So in her case, she had been drinking so much that she gave herself a really bad pancreatitis. The pancreas is responsible for secreting insulin, which is the hormone that helps you control your blood sugar. And so with her really bad pancreatitis, she developed an insulin deficiency that caused her to go into diabetic ketoacidosis. So this is just issue on top of issue on top of issue, not to mention her liver failure with the elevated bilirubin and the elevated ammonia. So we intubated her initially for that mixed metabolic and respiratory acidosis. Generally, when you have a metabolic acidosis, you'll compensate by breathing faster. And so her PCO2 should have been closer to 20 rather than 60. She was on the wrong side. So we intubate her to breathe for her to try and improve that acidosis. We put in a central venous catheter and an arterial line because after we intubated her, her blood pressure dropped. And so we had to start her on vasopressors. We gave her antibiotics in case there was a component of bacterial infection. And we did our best to resuscitate her. And so by the time she was ready to go to the ICU, she was actually awake and following commands, which was a big improvement. So what does the ICU care look like for somebody with pancreatitis? And primarily it's supportive. So we put you on an insulin drip to control your blood sugar. You're not producing insulin from your pancreas, so we'll give you some exogenously. We may do renal replacement therapy. So we started her on dialysis, where they basically clean their blood the way the kidneys would, but we do it through a machine. That's what she needed that catheter for. We gave her blood pressure medications to support her blood pressure. If you don't have a high enough blood pressure, then you're not sending oxygen to your tissues, and oxygen carries blood, blood carries, you're not sending blood to your tissues, blood carries oxygen. And so you're going to have an oxygen deficiency in your tissues and go into organ failure. So you need vasopressors to keep your blood pressure up. She was intubated, so she needed ventilator management. She was getting antibiotics. And then anybody who's on a ventilator generally gets sedated. It's not a comfortable thing to have a tube down your throat and being forced to breathe. So, but for pancreatitis, there really is no direct therapy. It's all supportive care, trying to allow your body to heal. And unfortunately, it can make you very, very sick. So ultimately, she progressed to multi-organ failure. The family was gathered and she was made DNR, which means do not resuscitate, meaning that if her heart were to stop, we wouldn't do CPR. That conversation was somewhat complicated by the fact that she was estranged from her mother, who's the default decision maker in the absence of a medical power of attorney. So if you come into an emergency room and you can't make decisions for yourself, when we're deciding whether to give, for the most part, if there's a therapy that's medically indicated, we act in your best interest and we try and do it. But when there's a judgment call to make, where maybe the evidence isn't so clear, or patient preferences, we'd like to take those into account, then you need to find somebody to be that decision maker. And so if you've designated that in advance and somehow that paperwork arrived with you, which is fairly rare, then we'll contact that person and they'll make decisions for you until you're able to make decisions for yourself. In the absence of that, there's a default hierarchy of people who can make decisions for you. And that's specified by each state. In Texas, the order is spouse, if you have one. It doesn't matter if you're separated. So if you separated 20 years ago, they're still next in line. After that, adult children. So if you have a child who's 15 or 16 or 17, they don't count. But if they're 18 or older, then they are the next in line to make decisions for you. If you don't have any adult children, then it's your parents. And then if you don't have any parents, it's the next nearest living relative or a reliable companion. And so that really is kind of a judgment call. And so in her case, she wasn't close to her mother. And so they ended up getting the rest of her family together, and then they kind of agreed as a group on that she wouldn't want her heart restart if it were to stop, recognizing that on all of these other therapies, if her heart were to stop, even after all that, doing chest compressions was not going to bring her back. They had consulted nephrology to manage the dialysis, hematology to manage the thrombocytopenia that she was having, GI to see if there was anything they could do about the pancreatitis. They got the ethics committee involved to see if it was reasonable to make this young woman DNR, and who they should kind of involve in that decision making, and then general surgery to see if there was anything they could do for her as kind of a Hail Mary pass. And so she was eventually made comfort care and then passed away 2 days after admission. So it was a tough case. She was very, very sick. And we did our best in the ER and they did their best in the ICU, but ultimately she did not make it.
So Avi, where is it ever allowed that we make judgments for people where they live, where they stay, they are homeless or whatever? Do we make any judgments as far as how we make our life-saving decisions for these folks, the treatments? Do you follow my question?
I guess the decision-making process doesn't change regardless of their socioeconomic status. So I don't care what color you are, I don't care how much money you have, but I do care about your values. If you're a Jehovah's Witness, then you don't accept blood products. And so I will honor that to the best of my ability. And I will explain to you why I think a therapy is necessary and let you decide what's more important to you. By the similar token, if you would express to your family that you would always wanted to fight to the end and you would never want to have care withdrawn, then that's something that kind of will help inform the decisions that I make for you. And if somebody had said, you know what, I never want to be on a machine, then that's important for me to know as well, so I don't take us down that pathway. But no, I don't. I guess where you came from and what you've gone through in your life does not change the decisions that I make or the pathway that we go down.
All right. So Avi, Priya asked us a good question. How are these decisions made when the siblings don't agree? So you've got a bunch of different people disagreeing about what to do. What do you do about that?
Generally, it's kind of like inertia. So you just end up, I mean, the default is to continue providing care. And so what you'll end up with, and this is something that I dealt with a lot in the ICU, is you'll have some family members that say enough is enough. They wouldn't want this. We shouldn't do this. And you'll have another family member who says, I'm not ready to let them go. We can't stop. And so when the patient is that sick and you're thinking about having these conversations and making these decisions, ultimately, it's not about the patient. To some extent, it may not be about the patient anymore because you can't help them. That outcome may be unchanged. It may just be a question of when. Like, they're going to die. Are they going to die now? Or are they going to die later? But the people who you will make an impact on are the surviving family. And so if there's something that I can do to make, like, to help them, then I think that may ultimately be the greater good. If they said, you know what, we understand. So take somebody who's brain dead. That's defined differently, or not so much defined differently, but every state kind of has laws regarding brain death. And when somebody's brain dead, you no longer need to provide care for them. They're dead. They may still have a heartbeat. They're not going to be breathing, but their body is functionally alive, but their brain is dead. And so they're recognized in, I think, all states as being functionally dead. At that point, I have the right to take out the breathing tube, take them off any blood pressure medications, and just let their body stop functioning. But a family may say, you know what, we have family that are on their way, and it would really mean a lot for them to see this patient before they die, to say their goodbyes. And so even if it's not medically, I can't say whether it's in the patient's best interest or not to be kept alive when they're functionally dead, but I can do something for that family that's going to make more of a difference than any decision I make for the patient at that point. And so navigating some of those issues and getting the entire family on board and in a place where they can all be satisfied. You don't want any of them to feel like you killed their family member, or that there's something they could have done that they should have done. They're going to have to live with the events that occur for the rest of their lives. And so as much as you can do to kind of ease that process for them, at some point, if you can't change the outcome for the patient, then that's what I would focus on. But sometimes it's not that clear, and we'll talk about that in our next case. And there's no easy answer. That's when you may get ethics involved. The social worker is going to be key, developing a rapport with the family and trying to understand. The way that I frame it is I ask the family to come together and help me understand what the patient would want for themselves if they could speak for themselves. Because while it may be about the family, if you can't help the patient anymore, when these decisions are difficult, or when the patient still has, I guess, some choices to make, it's important to keep them in mind because they are the patient. So you're saying, you tell them, I don't want you to make the decision based on what you want. I want you to make the decision based on what they would want if they could speak for themselves, because you know them better than I do. I didn't get a chance to meet them. By the time I met them, they were very sick. They were intubated, they were sedated, they were unconscious. So you have a better sense of what they were like and what their desires and wishes were. And so is this consistent with their values and their goals, or is it not?
Yeah. All right. So Avi, let's move to your next case, because I think the next case is going to be really interesting. Can we go?
Sure. So this is an 18-year-old female. She was ejected from a vehicle in a collision. She has multiple lower extremity injuries that required external fixation by orthopedic surgery. So if you've ever seen kind of people with metal sticking out of their legs in kind of a halo formation, that's external fixation. That means that something is holding things together on the outside of the body, as opposed to internal fixation, which is underneath the skin and you don't see it. So I got her as a patient in the ICU. She was intubated before she was admitted to us. When we examined her, she is unresponsive. She's not breathing spontaneously. Her pupils aren't reactive. She looks like somebody who may be brain dead, but it takes a while to make that determination. So her mother's there and tells us a bit more about her. So she's the first in her family to get admitted to college. She hadn't even started yet. Mom was a hairdresser. Her daughter were her hopes and dreams. And so what mom really wants to know from us is, what kind of life can the patient expect to have, and whether or not she should withdraw care. We have somebody who looks like they're pretty much brain dead, though we haven't proven it yet. We get a CT of her head, and there's really no injury there. So we don't have a good explanation for why she's not awake, why she's so unresponsive. We can't get an MRI of her brain because of those external fixation devices that were applied by orthopedic surgery. They can be magnetized, and so we can't put her into the MRI machine. And ultimately, when you're trying to diagnose somebody with brain death, what you need is an exam consistent with brain death, and you need some sort of structural lesion that would also explain it. So you need something on imaging that that says, you know what, this would explain why she's not waking up. In the absence of that, you can't declare somebody brain dead. So we presumed her to have diffuse axonal injury. Essentially, that's shearing forces that injure the nerves connecting the cerebral cortex to the rest of the brain. So you won't necessarily see anything on CT scan. You may see it on MRI, but patients will present in a profound coma. Recovery can be really variable and is difficult to predict. Some people come through and regain all of their neurologic function. Most people, if they do survive, have some sort of deficit. And there are a lot of people that never wake up. So one of the things that patients, and most especially family members, often don't understand when they're making goals of care decisions is that there's often a window of opportunity at the beginning of a severe illness to make a choice. So if you ask most people, I think they'd likely say that they wouldn't want to live on a machine as a vegetable for the rest of their life. In an absolute sense, the only way to guarantee that is to never get on a machine to begin with. But it's really hard to predict that outcome with any certainty. So a lot of people take a let's try and see approach, thinking that they can revisit the decision later. The problem is that when a patient is critically ill and you decide either to not provide or withdraw certain forms of life-supporting care, the patient will die. If this girl came in who wasn't breathing spontaneously and we took out that tube, she would, because she's not breathing, die fairly quickly. But if you wait long enough, we can often get to the patient well enough that they no longer need the most critical forms of life support. Maybe now they can breathe on their own and they no longer need blood pressure support. At that point, if you want to withdraw care, you're essentially starving them to death. And that's not a choice that many people feel comfortable making. The window of opportunity has closed. And so I think that's something that I wish more people understood when they were making their decisions about kind of their goals of care. So I didn't know what to tell the mother when she asked me that question of whether we should withdraw care and what her likelihood of being a functional human being again was. Ultimately, we chose to wait and see. And the patient ended up getting transferred to a rehabilitation facility. And so I looked her up a few months later, and I actually found a TV interview that she did from that rehab facility where she was awake, walking, talking. I don't know if she'll ever attend college, but I do think that she managed to achieve a quality of life that her mother was satisfied with. And all the indications we had at that point in time were that she would not recover and that was as good as we were going to get. What I told her mother at the time is, you need to, I guess, envision that this is, things can only get better from here, but this may be where we're left with. So I can't promise you that she'll ever get better. And so you need to make a decision about whether this is, this level of function in life is something that you're okay with. And so I was wrong. I did not think that she was going to wake up and recover to the degree that she did. I'm glad that she did. So it kind of gives you a sense of how poorly our prediction skills are, especially for brain injury. But I think that it would have been reasonable for her mother to make a choice to withdraw care initially.
Avi, what you're saying is the fact that so very often in our work, we're trying to predict what's going to happen with a patient, but we don't know. We think we know, but we don't know. And just like on this case, you had no idea what the outcome was going to be on this patient. And it turned out that she had kind of a reasonable neurological outcome. It could have been otherwise, but so very often we just simply don't know in advance.
When it comes to goals of care, I've had a lot of conversations with people about whether they would want CPR. And I just don't think that they understand the realities of it. They're like, well, let's see if it works. But if it works, you most likely are going to end up. So most people don't survive if they need CPR. And if they do survive, a good majority of them end up with a neurologic deficit. And so it's not like, let's see if it works and I get back to normal. It's let's see if it works and I might be a vegetable or confined to a nursing home. And I think that if most people understood the likelihood, people in general, humans, are really bad at risk assessment. And so I think that if people understood what their chances are, then they may not make the same choices. And for most people, it's not a question of whether or not they'll die. It's a question of whether or not they'll die with broken ribs at the end of their life.
Wonderful. Okay, what's next, Avi?
Those were the cases that I was going to present. So I was going to open it up to questions at this point.
All right, Taylor. So what do we have for our next session of questions for Dr. Ruderman, please?
Okay, let's see. So as you see various cases in the ER, what do you think are the most important areas for research? Oh, I didn't read the end of the question. It's kind of unrelated, but any specific areas in research or in providing healthcare that you feel is overlooked?
I guess that's kind of a subjective finding because I may feel like something's overlooked, other people may not agree. I've been listening to some podcasts lately talking about how a lot of the therapies that we think are helpful don't have a very good evidence base. And so, to be honest, we probably need to redo everything that's been done already to verify it and validate it. So it was done once, somebody said that it worked, but it hasn't been proven in multiple places by multiple people. And so I think that really everything could probably be use a good look at what's going on. There's different kinds of research. The field's wide open for you.
Okay. Another one is, in what ways do you see healthcare changing, or like have you in any way from your transition from, I guess, being a medical student to going through residency and being an attending now?
Well, electronic medical records was a big change. So when I was a medical student, my hospital was still using paper charts, and it changed to electronic medical records right as I was coming through. So that's probably the biggest change that most doctors who are currently practicing can tell you about, having lived through that. I think going forward, I'm hoping that artificial intelligence becomes a bigger function in the field of medicine. I think that that's there's a lot of potential there. Like, for example, they can read chest x-rays just as accurately, but way faster than radiologists, probably similar to other scans. I think that if we were able to figure out a way to get more people healthcare coverage and just overall make people healthier, that would be a great change. I don't see that happening anytime soon, but it's a hope. So people don't need to come to the ER for their chronic diseases if they have another place to go, or if they can get kind of on the right treatment pathway before it becomes critical.
And I guess like kind of related to that, do you think there'll ever be like robots that kind of like replace physicians, like a robot radiologist where, they're less likely to make mistakes, they're faster at it, more efficient? Do you see physicians in the future maybe being replaced or partially replaced?
I think there are some fields where it may be more likely, but especially when it comes to procedures, we have not, I think we're a long ways away from robots taking over that aspect. So I don't think so, not in my professional lifetime.
Okay, and someone who's wondering, what would you say the most interesting case is that you've worked on? I guess like a couple that you might remember.
I feel like what may be interesting to me and interesting to you may not necessarily be the same thing. So there's a case that stuck with me from residency. It was a relatively young woman. I want to say she was either in her late 20s or early 30s, who came in with chest pain and a fast heart rate. And she had a history of breast cancer, which is surprising for somebody that young. And she was supposed to be on tamoxifen, which is an estrogen receptor antagonist, but she had gone off of it because she wanted to get pregnant. And indeed, she was pregnant with twins. And so we needed to figure out what was causing her chest pain and what was causing her elevated heart rate. And so we decided to get a CAT scan of her chest to see if maybe this was a recurrence of her breast cancer and whether she may have had a blood clot. And so that was, at the time, research was still kind of emerging on the dangers of getting a CAT scan on a pregnant person. And these days it's recognized that a CAT scan of the chest is not something to be too worried about in a pregnant patient. So, but at the time it was a bigger deal. And so we did that, and we found that her breast cancer had recurred, but not in a way that really explained her elevated heart rate. And so we got thyroid function testing and found that her thyroid hormones were elevated. So that was probably the cause in that. The issue we ran into at that point is you're pregnant and you now have breast cancer. She's only a few weeks in. Do you delay therapy for the breast cancer until you deliver, hoping that it doesn't progress to the point where it compromises your ability to deliver that child? Or do you end up aborting this pregnancy so that you can get chemotherapy? And so she ended up following up at another hospital, and I wasn't able to keep track of what happened, but that's something that kind of stuck with me, having to deliver that news and talking to her about the next steps. So I thought that was a really interesting case.
I guess, and also a really emotional one, like if you were, emotionally tied to that situation.
So, and there's always going to be things that kind of speak to you depending on your own life experiences. There's a ER doctors Facebook group that I read through pretty frequently, and it's not an infrequent post to see somebody say, I had somebody who was 5 or 7 or 10 years old come in who's coding, and they reminded me of my own child who's the same age, and I went home and hugged them super tight. And there's some really terrible stuff that happens in this world, and so you may see things that are a trigger for you, and that's just part of the job. So we see some of the best and most of the worst that happens in this world.
Let's do one more question for Dr. Ritterman. Taylor, would you?
This was one that I kind of personally had, I guess, just because you brought up kids. Why wouldn't you have done pediatric emergency medicine or critical care?
Oh God. The whole reason I did a critical care fellowship, forget everything else I said, it's so I never had to see a kid again. Either the kids are sick and I want nothing to do with them because they're sick, or they are not sick and I again want nothing to do with them because they are not sick and they do not need me. And it most likely over worry.
So Avi, why is that? Because, Peter Antevi spoke to us last week. Peter is a pediatric EMS and emergency medicine doc. And I said, Peter, I can be at the bedside of an adult and just feel their pulse and put my hand, and I really feel a good sense of what's going on with them. But for kids, I don't have that feeling. And is that your case, Avi? Is that you just don't have that feeling?
Probably. I should also let you guys know that there is no route to doing pediatric critical care from emergency medicine. So the only route to that is to do a pediatrics residency and then a pediatrics intensive care fellowship. So that's never going to be a possibility. With kids, they don't have responsibility for their health. And so that makes it challenging when you have to rely on the parents. If they're not vaccinated, it's not their fault, but you now have to work them up for these diseases that they shouldn't have. They can't communicate as easily. And an adult, that's fine. I can just get CAT scans and lab tests and figure out what's going on. In a kid, it's very different. We don't want to expose them to radiation that they don't need, that increases their lifetime risk of cancer. Getting an IV on one of these kids is really difficult. They're screaming and crying and upset. If an adult doesn't want to participate and cooperate, then I can say, great, when you're ready for care, let me know, but I'll see you later. If a kid decides to scream and cry and refuse to cooperate, I still have to keep trying. And that's frustrating. And then the risk is so much higher. I mean, there's so many things that can go kind of wrong with kids, and but most of the time it's usually nothing. It brought me no joy to take care of kids, and so now I don't.
Well, that's good to know. Dr. Valor, do you have any closing questions or comments that you'd like to make?
No, Avi, thank you so much. What a wonderful session for all of our team here. We've had over 200 people sitting on the edge of their seats listening to you tonight, Avi, and it was just wonderful. And thank you, Taylor, for hosting this group. We really appreciate it. And so everybody, now, Taylor, do you have some information about how they take the exam and so forth?
Yes, one more slide. So this is assessment 74. This is the QR code. We're also going to post it on our Instagram story, so you can find it there as well. Just be sure to scan it and get this completed before our next session at 6:59 p.m. on the 26th, so you can get credit for participating.
I'm not seeing it yet. Am I missing something, or
it's on the screen. Can you not see it?
Does everyone see it? I don't see it, but maybe I'm missing it.
Someone sees
it.
it.
Oh, there it is. Okay, there it is. Sorry. Okay, so we're good. All right, so everybody, thank you so much. And Avi, I just want to really express the gratitude on behalf of the whole working group for you coming and joining us tonight. We really, really appreciate it. Your very measured words about the future of how these kids, as they are applying to school, need to think about what it is they're doing and what it is they're going to be doing down the road. So we very much appreciate it. So folks, on behalf of the whole working group for virtual shadowing, we thank you for coming. And we're going to be here as long as you as long as you keep coming back. So on behalf of the whole working group and Dr. Ruderman and Taylor, we just say thank you so much for coming. And we wish you a good evening and a good night.